So guys, now our recorded session has begun. Now I have gathered your question, which has been thrown in my inbox. So now this question, what it says, for the lab, will only the group of people you chose be allowed to physically meet and perform dissection and other are gonna be online? If yes, will this group rotation each week? No, it's not weekly, it's after a block. And I wish when this pandemic is over, I love to see you all physically. You've been missed a lot. I don't think this question need any further explanation. Going further, I think I should minimize this image here. It's hindering my, yeah, it's good now. Okay. So can guys, I'm just putting your copy paste. Can attend the labs with you in campus on Sunday because I am a visual learner. I think I will benefit a lot of it. Don't worry, we'll see to it how it's possible. Now, for the lab, will only the group of people you choose be allowed to physically meet the cadaver? Yeah, I wish. I love meet the cadaver, meet and greet, and perform dissection and others are gonna be online. I think it's a similar question. So I answer for this question. Wait for the time. I want to ask you if and come in the morning or any time to the lab to study bones and joints. Yes, you can. But for that sake, you have to confirm with our lab people. Currently, we have only one. We had two, but we lost one due to COVID. So now we are having only one person, and that person will help you to allocate you that there is a time. So book with him, and you can have an access to the lab. You can, but not in a crowd. So you can come, you can have physical encounter with all this resource material. That's not a problem. We are here to help you. We are not here to penalize you. So now can I volunteer in the lab? I don't get a message. I answer this question. Sure, I love you to be in, but wait for the good time. And how this good time will come? You'll be, shortly you'll be noticing one more thing. Each lab space, there will be cameras. You're requested to cover and all that, so be careful. It's not recorded, but for quality purposes or for some other reason sometime it might be recorded, so you should follow all the necessary precautions, and we will be observing you. You don't see me physically there, but I'm there always. So we can see that who's a smart kid in this group. Maybe that person can get an independent email. What do you think? You want it to be? So it's not maybe, you didn't ask it maybe, but you've been, and there are one or two, we gave a choice that if you don't want to be a tutor, peer tutor, you can send your regrets. I'm glad 2 people has shown decline. So 2 more people can be accommodated. So I have vacancy getting up. So I want to be a volunteer. Yes, I answered that. Now, the subject related material. Rotator cuff muscles are deep or superficial. This is a very commonly asked questions. People ask this question in relation to so many contents. Guys, take an example. Onion. It has layers. Human body has layers. The inner structure is skeleton, which is being overlapped by muscles. In between, we have organs. And these muscles are covered by different facial linings, and ultimately is covered by skin. So we have layers of these structures. They are not placed in one plane. Like you're wearing your dress. You have your undergarments, you have your dress, and then you have your protective PPEs or whatsoever you call it. Your coat and abaya and your jackets and all those things. Am I clear? So similarly, these rotator cuff muscles are the deep group of muscles. Now another question, I will not say it now, let it come. So I hope I'm clear for that. Any concern for this question? Now, is supraspinatus tendinitis same as painful arc syndrome? Yes. My next slide will be when I'll start my thing, then I'll be talking about I discussed with this issue yesterday, but it was in a small note. But today I'll be talking about it. Yeah, you'll be finding it today. So, what exactly is a ligamentum nuchae? Ligamentum nuchae is extension of fibrous band, which is starting from the base of the skull posteriorly, and it goes down all the way. It's been placed on the spines of cervical vertebrae. That's called ligamentum nuchae, and my this muscle trapezius is being getting anchorage to these spinous processes of cervical vertebrae. So this is how this ligamentum nuchae is a common. Let's see, you can see a bar. When you want to climb, you can hold it, and so this is something like that. So this ligamentum nuchae is a central tough structure, and muscle fibers has been coming from that. They are attached there. So it provides a base on the basis of whom this muscle, when it contracts, when it performs some action, so that's the basis, that's the place where it can move in and out. Next question, should we memorize proximal and distal attachment? Because I think it's the same as origin and insertion. Sorry, my dear, it's not the same. I have one example, I'll show it to you. Origin and insertion means details. Proximal and distal attachment, let me give you an example. My deltoid muscle is coming from acromion, from clavicle, going to humerus. That's it. One was proximal, one was distal. And if you ask me, 2 centimeter here, there, blah, 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 these fibers, medial fiber, lateral fiber, superior fiber, no. Don't waste your time. That era is gone. If you want to learn classical anatomy, 100 years back, if you are 100, more than 100-year-old, yes, you should. But now that era is gone. Nobody needs it. Alhamdulillah, I have done good practice of orthopedic surgery. We don't need these things even in operations. Functional parts, more important thing is functionalities and the innervations, nerve supplies. That's most needed, because even if you learn it, you will forget it. I had a confusion regarding visualizing the intrinsic muscle of the shoulder location. I know they are located on the scapulae, but as in their location according to the trapezius and the latissimus dorsi, and whether they are the deep or super. Guys, I told you they are arranged in layers. So my superficial layer, if I start from the back, the most superficial under the skin are two, trapezius and latissimus dorsi. When I reflect them, underneath I can see the levator scapulae, rhomboids major, rhomboids minor. If I go to scapulae, within the scapula there are small group of muscles. They are going to the head of the humerus. Now they are the deep group of muscles, but they are localized in a small area. Let's say I have so many muscles, small muscle who are present in my hand. So they are intrinsic muscle of my hand. I can give you another word for that. You use a very common word here, dakhli and kharji. So intrinsic is dakhli and extrinsic is kharji. So any muscle coming from here going to my fingers, that's an extrinsic muscle. And any muscle coming from this part and going here controlling these fine movements, that is intrinsic. So similar is happening in different small zones. Am I clear? Okay. Do the superficial posterior extrinsic muscle include the latissimus? I think I have answered, but you're mixing up. Rhomboids is the deep, it's not superficial. Now, this is an interesting question, and that's why you can see it's been highlighted. Levator scapulae muscle is assisted with, is attached with, basically you have to write attached. I put the same words what you have done just to correct you. With vertebrae C2 to C4. Guys, remember one thing. Any book which is written, it is based on a basis of observation. Let's say if I take 10,000 cadavers and I observe levator scapulae muscle is attached to which vertebrae, I have an evidence and I document it. My other colleague, he find another community, let's say he is working on Chinese. In Chinese population, he has seen there is one extra string, maybe one less. So his book will be different from me and my book will be different from him. Somebody asked me, I didn't put that question here. Which books? Guys, there are, my iPad has more than 400-500 textbooks with me. I'm carrying all the time with me. These are the best ones. But there are some thousands more. So you don't need all that. You need more grace for gross anatomy. Use one atlas for watching pictures. That's it. Histology, Oni will tell you. Embryology, Paul have told you about. And these books have been mentioned. Don't waste your time. Every book talks the same. Pectoralis major will remain pectoralis major no matter you see in a Russian or in an American or in a Caribbean or in Finland, it's pectoralis major. Maybe it sounds in a different language, but it remains pectoralis major. And its action will be the same. So no need to waste your time. Now, this person was asking C2 to C4, but I have reviewed Gray's Anatomy book, and it says that it is only innervated by branches from the anterior rami of spinal nerve C3 and C4 only. Now, you are playing, you're into, so originally you're saying C2 to C4 is the nerve we are supplying, but your Gray's Anatomy says C3 and C4. Then I thought, oh, I made a mistake. So then what I did, I opened my Gray's Anatomy. I look for this muscle. It's very small. I don't know you can read it or not. I just pick for, because your concern was nerve supply. So that is highlighted. And now Gray says, levator scapulae is innervated directly by branches from third, fourth cervical vertebrae, spinal nerves, and from the fifth spinal nerve via the dorsal scapular nerve. So this you will understand when you learn brachial plexus and all those. But you can see that third, fourth, and fifth has been mentioned. So you are saying, so which Grace is this? This is that Grace. This is not your Grace. This is Grace for adults. The book Grace you are learning is Grace for babies. This is Grace for adults. It's this thick and this big. And now, what you're quoting, what you're referring at is this. You can see that it's in your inbox. C3, C4, and C5. This has been given to you. So please, when you're quoting something, just reconfirm that what is being visible at the source. Do you see any difference between these two? See here, C3, C4, C5, and see there, down. Are we good? You got the answer? So you I know, I like it. You bother this much, but please recheck. Now, just to clear up the superficial deep, so these are the superficial layer muscles. You're looking at trapezius and latissimus dorsi. Deltoid is being shown. Now, we have cut the latissimus dorsi and trapezius. And now you can see these are the deeper layer muscles. So they are on both the sides. And now the muscles which are localized to the scapulae region, supraspinatus, infraspinatus, teres minor and teres major, they are intrinsics. Where? In the scapula, on the dorsal surface. Are we clear?
Yes. Someone's asking, what is the fascia beneath latissimus dorsi? Isn't that a muscle?
Thoracolumbar fascia. Thoracolumbar fascia. So now this is a schematic version of showing you the same. This slide has been shared with you. Nothing new. Okay. How is shrugging used in clinical neurological examination to test the integrity of the spinal accessory nerve if the nerve that supplies the trapezius and levator scapulae are supplied by cranial nerve 11 and dorsal scapular nerve? Gentlemen, or I don't know, whosoever person is, you have to be clear. The nerve supply for levator scapulae is different. The nerve supply for trapezius is different. The nerve who control my trapezius is 11th cranial nerve. And if I want to check 11th cranial nerve, I ask the patient, shrug his shoulders. And if he can do that, yes, your 11th nerve is good. For levator scapulae, I should look for some other option because its nerve supply is different. You are confused yourself, but please check it. By asking these, I don't mind. At least by asking, and I put this question, because if he lives with some kind of confusion, correct it. You may come the similar question in the exam. Shrugging of the shoulder is testing which of the following nerve? 11th nerve, dorsal scapular nerve, lateral pectoral nerve, medial pectoral nerve. So, if you are exact dot clear, you can answer this question. Okay, what is bursa? Bursa is a sac of mucous membrane filled with Synovial fluid, excellent. So it acts like a cushion and it minimizes the friction. Your second part of your question is, and is it found only in synovial joint like shoulder? Guys, we find these bursa everywhere in our body where we have friction. Let's say, let me put an example, around your knee, there are more than 12 to 15 bursas in front, behind, on the sides, under the skin and under the muscle and blah, blah, blah. So bursas are cushions, and these cushions are doing what? They are there to minimize the friction, helping, smoothing out. Am I clear? Okay. If the person has winging of the scapula and the long thoracic nerve damage, perfect, the long thoracic nerve damage causes the winging of scapula, or the other muscles will be affected and the person cannot move the shoulder or only the serratus anterior muscle. Obviously, long thoracic nerve is designed to control serratus anterior muscle. If this nerve is damaged, only my serratus anterior is affected. Or if this nerve is supplying any other muscle, that muscle will also be affected. But it will not affect the whole shoulder joint, because my shoulder joint, there are so many muscles who are acting there. It's not only serratus anterior. Make sense? So specifically for serratus anterior, we have long thoracic nerve. And if long thoracic is lost, scapula will not stay, not in normal situation. When you apply pressure against the wall, I remember last year or before last year, there's a student in our class. When I was teaching this, he stood up and he took off his shirt and he shown to the whole class, look, my winging. You know, we have, and then I know there are two more people in our uni. They have winging of scapula, but they're living a normal life. Only this winging of scapula is obvious if you apply pressure against a wall, and if this muscle is not working, now scapula will not be stabilized, it not be sticking with your body, so it will be popping out. Not being thrown out, but this border will become visible, the medial border, because the serratus anterior muscle is attached. I hope I am able to answer your question. Now, this is the best slide, I enjoyed it. This gentleman says, I hope you are well. I started counting the vertebrae according to the slides and at the beginning. So, gentlemen, please look for a good ophthalmologist. You need one. Because guys, help me if you can see that. In one of the slide, he, even his numbering is different. Other slide, he missed one digit. So, and remember, these are my hand drawings. These are not, even the textbooks which you see, if a textbook has to be developed, it takes 5 years to come in market. But here, if you just look back into this numbering, I think it's fine. Because I just looked at it carefully that maybe this person is right. Like somebody was asking me, I put a wrong label for, there were two pictures beside. So the label of this picture was put under the other, and then I said, thank you very much for identifying this reason. So, but there is no problem, just recount it. Anyway, I put it for, like, if you have even, I accept this type of question even, but not for a, on a continuous basis. Those questions which will help you to score your grades and all that. Now, we are done with the questions, and those whatsoever have received in my inbox till 7 this morning has been addressed. Intrinsic and extrinsic, I didn't put it, but I talked about it. So I think I have covered all those people who are asking me in different time locations. So now this slide, we talked about it. Now here I'll be showing you what the label says, intrinsic muscles. So now, before that, this is the capsule of my shoulder joint. We talk about, when we are talking about a synovial joint, we talk about one of the integral factor for a joint to be called as synovial, it should have a capsule, fibrous joint capsule. And internally, this capsule is lined by a synovial membrane, and that is responsible for releasing synovial fluid. So now there you are looking at, now there is a muscle which is coming above to the spine of the scapula onto the posterior surface or the dorsal surface. That is above to the spine from the supraspinatus fossa. We call it, this number 1 is supraspinatus muscle. I told you this muscle is really, really, really important and it matters a lot. Then we have Now, can you see that? This one was moving. Why is moving? Somebody, because this muscle, can you see that? It's going under cover of bone. Below to it is a bone, above to it is a bone. So it is being trapped. And if I'm doing too much at my shoulder, let's say I'm working out a lot, I'm involved in too much swimming and all that, I'm preparing for some competitions and these things. So there is a susceptibility that too much exercises or then aging, and there are so many factors. So this tendon, this part of the muscle, well, it's well surrounded, it's well protected, there are so many bursas here, but still there is a chance. So this can undergo some degenerative changes, and once it's there, and it happens not with all but so many in old age, if it is involved, it become inflamed, and then it cause pain, and this inflammation is being gone to these bursas, and then we have bursitis and tendonitis. And I talk about this term itis. If you put word itis at the end of any normal structure, it becomes inflammation, appendix, appendicitis. So many examples. So now this is supracondylar tendonitis. So now this is my infraspinatus muscle. Name is suggestive, it's below to my spinous process, infraspinatus. Are we clear? So now this action has also been given. Somebody was asking me about actions. That, I told you, I write actions with blue. I write, my boxes are red. You can see these boxes. They have clinical relevance within the slide. Your mood write blue boxes. Grays write green boxes. And don't miss these boxes. They carry a lot of your exam material. We use them a lot. So blue, somebody was asking me that at the end I will show you those, that there are some tables and there are, so no matter if you're asked to talk about the actions performed by trapezius, you read through my blue lines, blue words, or you read through any book, we need right answer. So there is no restriction. Use any resource. So many people use Wikipedia. Please be careful. I call Wikipedia as public toilet. Anybody can go and put a wrong information, there is no control. Well, there are so many authorities who are there to check and recheck and to correct the infos, but please be careful. Wikipedia infos are not always correct. So don't trust them. And somebody was quoting me yesterday, there was one email from a good student, I remember. And that person was asking, in website says this. I said, please don't quote website. If you're quoting, quote a journal, a good index journal, not a journal which is published in Batha, or quote a good book, a standard book, then it's fine. Even if I'm given a reference from a book and I'm getting a reference from an article, I'll go with the reference from an article, because article can be recent. Any info which you can see in a book is 5 years old minimum. Anyway, it comes with the time. It's early. So now this green muscle is my teres minor. And now let's come into this image where you're looking at from the anterior aspect of the scapulae, and this number 4 is my subscapularis. So these 4 muscles, I said yesterday, you can see that they are giving my SITS, sits. And these sits are rotator cuff muscle. They are deep group of muscle. They are intrinsic muscles of the scapula. And they are the chief stabilizers of my glenohumeral joint, shoulder joint, in your common words. Are we good? So now we can see that the sides, now the nerve supplies. Guys, nerve supply, there is no excuse. Attachments, there is an excuse. But nerve supplies, you should be good. Suprascapular nerve, and for teres minor, there is an axillary nerve. And for this subscapular is upper and lower subscapular nerves. Now, so many people were asking me, do we need to remember this C5, C6, C2, C3? Guys, not for every nerve. Big nerves. And I will tell you which nerve you should remember. This one, if you don't, axillary, yes, out of this box, on this slide, you should be good with axillary nerve. That what is the root value? We call it root value. So axillary nerve, about that you should remember it is C5, C6. Others, if you don't remember C5, C6, and guys, different book says, somebody will say C4, C5, C6, somebody says C5, C6, somebody says C5, C6, C7. It's okay. No one is dying. Your patient is not dying because of that. Patient is dying because of loss of function, not because of this comes here or this goes there. Variations are there. So all we talk about sits, and these are the rotator cuff muscle, and they are very important factors in stability of my very mobile joint of my body. That's my shoulder joint. Now this picture indicates how these sit muscle attach. We talked about it yesterday. So just for your queuing of your info. So this is how you can remember, because head of the humerus has greater tubercle and lesser tubercle, and you can see those three, which three? Supraspinatus, infraspinatus, and teres minor. They goes there, and subscapular is goes to the small tubercle. So this is how they are attached, and basically they are keeping the humerus towards the body, because in my shoulder joint, I'll be talking, my next presentation is about that, so I'll be talking more details there. So they are keeping the humerus towards my body. So my hand is not, does it happen? You are standing or you're running and your hand fall down? It never happen. So there are factors, there are forces which keeps it connected. Now, somebody was asking me painful arc syndrome. You can see that when you do this section, if your supraspinatus tendon has some kind of tendonitis, bursa has bursitis, so this movement become severely painful, and it become almost impossible. And this person experienced significant pain. Usually those who are affected, women and old age. It's a common phenomenon. So now this is what I talked about it yesterday. I'm talking it again because it's really important, and we love to ask it again and again and again and again. You know, when you ask before the exam, what is important for this exam? So we talk within the lectures what is more important. So pay attention to these. So now what you need to see here, look here. Can you see that? This white, where this arrow is? That's important. That's the tendon undergo degenerative changes. And then this is an MR of a patient who has this arc syndrome, difficulty in bringing movements at his or her shoulder joint. Make sense? So that's, but not only the supraspinatus, others are also involved. I talk about supraspinatus, supraspinator muscle. It initiates the abduction up to 20 degree or 30 degree. From this degree to my 90 degree is deltoid. Above to that, trapezius and levator scapulae, they come in play. Rotation of the scapula, it does. So many things. Back to the same slide where we were. Now I'm adding one more muscle. Teres major. Please check your minds. Teres major is not a rotator cuff muscle. But this muscle has its own values. We talk about it shortly. So its nerve supply has been given and its action has been explained. Okay guys, so now I'm bringing deltoid. Deltoid is the one which covers everything. Rotator cuffs are under this, and this makes the bulk of my and your shoulder. So now this is, I'm showing you the bursa, under the deltoid, under the acromion, so we name it accordingly. The part of this bursa which is under the acromion process, subacromial bursa. Under the deltoid, subdeltoid bursa. Under the subscapularis, subscapularis bursa. So under, and according to the location. So we can name it. It's not a rocket science. So now inflammation of this bursa, bursitis, then there is a treatment, there is a plan, physio, rest, analgesics, antibiotics, plus minus steroids, local anesthetics. This all, but you need not to remember all that. This is you learn when you will be advancing in your phase 2 and phase 3 and phase 4. This where, and when you will be in real practice, these things you need to be expected to know, or not today. Today you should be knowing the anatomical basis. Yes, mice.
Someone is asking, Doctor, what does it mean with the lateral and medial movement of the scapula?
Oh, I love this question. Unfortunately, I don't have the picture of that. I think it's I'll connect it, but not now. Let me finish it, then I will show you. Because this scapula, it glides on my body. It has protrusion. I was talking protrusion and retraction. So that concept is there. So protrusion retraction, because the scapula it can glides, because it don't have any bony attachment with my chest wall. So it can move like that. So lateral and medial, protrusion retraction, even it rotates in different actions. So these kind of things I emphasize more in my lab sessions, because there I can show you, because I have the material with me. All this is not 3D, and I'm a person who believes in 7Ds. And 7Ds are only possible when you are working on a cadaver. Okay, so now treatment. Why I'm bringing it here? I told you you need not to know it, but you should have some idea. If someone has serious issues, it goes worst. Now, there is one of the option. It's good. This injection to be given in this joint space, in this inflamed area, intra-articular injection, an injection within the joint. So this is not an ordinary injection. Any ordinary nurse cannot give it. For this, you need to have a proper trained person. That person, the one who's authorized, can do it. Please don't try it. It's dangerous. It has its own hazards. You introduce an inflammation in a joint. You introduce an inflammation in a bone. End of the story. You might lose that part. You might need to cut it off. So be super careful. Don't try anything. So these are the injections to be given, and they are helpful, but short term, not long term. Okay, we are done so far. So now let's talk about quadrangular triangular spaces. For that, we need to talk about a muscle. That muscle is triceps. Yes. Hmm. Yes, I love your question. I still remember there was a lady sitting in my clinic, and I did a surgery on her, and she came for removal of the sutures. There was a special type of suture which was being applied on her. It was, I don't want to give you in detail, take you in details. So now this suture was so, like, after you remove the suture, you don't see the scar mark. It's that special type of suture. So, doctor, I'm wondering what you will do. Will you take me back to the OR and give me anesthesia and all that for removal of this suture? And I was just sitting quietly with her, putting my hand and just feeling as if I'm just, doing, looking at, and I hold it very quietly, and only this much was required. I pulled it out. I said, "Did you find any pain? Do you need some anesthesia?" "No, what you did?" I said, "Your suture is out. Period. Assalam." So, you don't need. For giving one injection, if you have to give 6 more injection, what is your choice? If you are given a choice, take one prick, and you are scared. So for to minimize that pain, you are ready to take 6 more pricks. What is the good option? Select yourself. You'll go for one. But as a human, we are scared. It has to be. But more you get into that, and the job of doctor is not a butcher. You come and chop, 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 chop. No. Doctor should have a human touch. In some schools in the world, now they have started that students should spend 2 years in learning human touch. They're exposed to different their curriculum has expanded to 7 years. 2 years have been spent in teaching other moral values so they can treat their patients as humans. I'm sorry, this is happening. Not everywhere, but some schools they're trying it.
So the scapula is attached more than 7 muscles.
Scapula, can you say again? Scapula is attached more than?
7 muscles. Different muscles.
Let me make your life easy. Scapula is attached on the inner aspect. We have subscapularis. Outer aspect, we have supraspinatus, infraspinatus, and then we have teres minor, teres major, serratus anterior. We have latissimus dorsi. We have trapezius. All of them are attached to the scapula somehow. And then story is not ending yet. we have the pectoralis minor, we have some, so we had a series of structures which are attached in different direction, from the front, from the side, from the back. So scapula is a sliding thing, it floats, and it's been connected by so many muscles, so it's wrapped in between. Visualize it that way. And this visualization will come when you're visiting lab. Guys, yesterday it was a, I wish I could have made a movie of that. We put the cadavers in the lab. Today, if you are having your lab today or tomorrow, you'll see it. Cadavers, we put plastic because, in the beginning, so plastic has to be removed. People were just looking through the plastic. Come on, go, remove it, touch it, feel it. And then I sent somebody, go and remove this plastic. They should not be there. They should touch and feel the thing. They should have a real perception. Otherwise, a good picture is why we need to put so much money in bringing these cadavers and dissecting them and doing blah 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 blah. So please, when you visit the labs, these questions like you're asking, I really appreciate. So these things you should be having in, and shortly you'll be observed with these cameras. These cameras are not only for your observation. You can ask questions because the sound is back and forth. Somebody is sitting at the control room, and that person will be facilitating you, will be helping you. And even if some question remains, please, like, what we want in the structure of the the lab session on Thursday, we want questions like this, so we can take one by one answer, connected pictures, connected explanation, so it can be more meaningful for everybody. Yes.
I know it's important to know the names of the nerve supply. It isn't even important to know that the C and the T and
My dear, I think when I was talking about this, you are not there, or if you are there, you are busy on your screen. It's important, but not everything. There is a priority. So at this moment, you need to be good with the major and more important, the big nerves, not the small ones. Otherwise, sky is the limit. Because you are not expected to spend years and years in MSK. It will be finishing in 6 weeks. 7th week is a review week. 14th of November, bye-bye, Saturday. So there is my triceps muscle, which is a muscle which present where in the back of my arm. And this muscle has 3 parts, so that's why it's called triceps. So this triceps, if you look at the arrangement of this triceps and my teres major, as a result of this, I have this quadrangular space. Can you see a small triangle down and a triangle down here? So these are quadrangular and triangular spaces. And these spaces are there to transmit some important we use a word, and you will be seeing me using a word a lot, neurovascular bundle. When I use the word neurovascular bundle, it means nerve, artery, and vein. In clinics, we don't say this artery, this vein, neurovascular bundle. Is it neurovascular bundle intact? Intact, proceed. Nobody has time for writing this nerve, this nerve. No. Neurovascular bundle intact, functionality intact, proceed. So who passes from where? That's important, and it's a very commonly asked question. Mice can tell you how many times she might have been asked this question. So now, from these quadrangular spaces, who passes? Posterior circumflex humeral artery along with axillary nerve. This upper triangular space, very tiny one. If you forget it, it's okay. But don't forget this one. This is my radial nerve and profunda brachii artery. This profunda brachii artery is a deep branch of my brachial artery. So you should be good with who makes the boundaries of quadrangular space, who's lateral, who's medial, who's superior, who's inferior. And the triangular space, who's lateral, who's medial, who's superior, who's inferior, blah, blah. This is a triangle. So there should not be 4 things, only 3 things. Mathalas. And quadrangular is murabba or mustatil, whatsoever you like to call. Are we good? So, but these contents are important and you need to be good with them. If not, you'll be losing. Straight away, you're losing some questions. Okay, so now deltoid. Let's bring deltoid. Deltoid covers everything. And then You're looking from the back. Posterior fibers, middle fibers, and anterior fibers. Each set of fibers is helping in different movements. Anterior fibers assist those muscles who are present anteriorly. Posterior fibers assist those muscles who are present posteriorly. And middle fibers are primarily working for abduction. Guys, try not to memorize everything. Try to visualize things. If you visualize things and try to do on your own body, you'll never forget it. It will be your lifelong learning. May you forgot for a while, but you can recall it. You can reproduce it. But just saying deltoid, middle fiber, middle fiber, middle fiber, you may be saying 20 times, and after 5 minutes, another muscle comes, and then all zero. No, don't do it. Develop a perception and try to feel everything in your own body. But don't do it in front of your parents. Otherwise, they'll start thinking, weirdo, what happened to my son or daughter? He's behaving something different what Al Faisal is doing. Don't do that in front of them, in your room. Are we good? Okay, guys. So now after that, these attachments and ultimately all this deltoid goes to one common place. The fibers converge, multi-pennate, convergent, triangular. You're asking me this thing. Is it triangular? Is it this? Guys, it's all we can classify it the way you like. There's no rocket science here. So this whole muscle goes to be attached to one common point, and the place where it's attached, if you're more muscular, your deltoid tuberosity will be more prominent, and that's a bony, bone marking. You're asking me about that. Do we need to memorize this for foundation? May not be asked in foundation. We ask you now. It's a continuous, lifelong process. You cannot say, this was the objective of foundation, why you're asking in MSK? This is the content of this and that, why because your patient is not like, oh, this is the doctor for MSK, only for upper limb, only for deltoid. No. Once you're a practicing doctor, you'll be dealing everything. Oh, I'm a doctor for facial nerve only. I can talk face. For lip, go to another doctor. For tongue, go to another doctor. That's not, maybe, sometime. Let's see. So the anterior fibers, middle fiber, and posterior fiber, what they do, that you need to know. And these are the blue lines. Don't forget them. They are important. And they are explaining you what? The functionalities. Functions, trust me, those who took exam last year, ask, there are so many in your class. They will tell you. The main emphasis of last year MSK was functions and nerve supplies. If this nerve damage, which function is lost? If this function is, there are so many. Ask them, trust me, they will tell you. And I'm not lying. I'm standing and I'm responsible for my words. Even Miles took my exam. She knows it. What we've been asking. And if, for attachments, we are ignorant, but not super ignorant. At least you should say this is a muscle of shoulder region. A shoulder region muscle, don't bring it in the gluteal region. There is a location for that. But action and nerve supply, there is no excuse. Okay, guys. So now we talked about it yesterday. Deltoid muscle, a very common issue. Okay, you have this problem, you have to be given an injection. Doctor gives you the choice. You want an injection here, or you want to have an injection in your butts? Up to you, your choice. So many times we like. Now, a nurse who give an injection may cause problems. Because the nurse only, he or she knows, doctor, I was taught that give an injection. Where? She don't have a reason why she is giving here. But you've been as a doctor. You should be knowing it, why I'm giving it here. There should be an anatomical basis of your understanding, and that's important. If you don't know it, it's problematic. Are we good? So now, how I can figure it out that what is because all practice of medicine is surrounding what? Safety. If you're safe, you are the best. And if you're not safe, nobody will come to you, people will sue you, you have to face the fines, your license can be taken, you'll be sent behind the bars, you have to spend time. So, why to get in that? Why not to be a doctor? So a doctor knows this injection to be given where. Even if injection to be given in the gluteus muscle in your butts, there's a space for that, not everywhere. So intramuscular injection, where? Here, here. What's the criteria? And trust me, this single injection, I know somebody very close to me. Husband gave this injection to the wife, and wife lost sensation from this area for 2 years. And she kept on cursing him. You destroyed my shoulder. Every day. And think if it's your patient. You'll be sued. So now we have to calculate. Rough calculation. Acromion process, you can all feel your own acromion process. Around 4 centimeter. Don't take a scale. You can put your 4 fingers around that. 4 centimeters. Stay in the midline. That's the place. You insert the needle, never push the medicine. First suck it. If you are in a blood vessel, you'll see blood coming in. Stop. Withdraw the needle. Reinsert. It's not a problem. But if you inject in a vessel, disaster begins. So you have to be careful. If you are involved in a process of giving an injection, always make a habit. The person who's standing next to you, you can see everything, but for an evidence, ask him or her, can you help me in confirming the expiry date? It's you saw it, but why are you asking that person? You want to have an evidence. If anything goes wrong, nobody should be blaming you. You can say that, yes, I checked it, and he or she checked it. And then you should know the proper place. So for everything, there's a technique, and you need to learn it. Swimming, if I keep on explaining to you how to learn, how to swim in a classroom, you'll never learn. Rather, I'll take you to a pool, I'll push you in the water. Some water goes in your eyes and ears, and then you will learn how to make bubbles. And then you're floating and, double stroke and all that, you can do it. So, if you damage a nerve, which nerve is here? Axillary nerve. It's sensory part. So you lost sensation in this area. Even you prick a needle, if patient cannot see it, patient will not feel anything. So if you have to check the integrity of the sensory component of axillary nerve, just feel for the sensation. The patient will not have any sensation. If the nerve is damaged, this sensation may come 2 years, 3 years, whatnot, or never come. And if the motor part is gone, deltoid is gone. Deltoid is gone, I cannot bring abduction. Got it? So axillary nerve has sensory and motor component. You have been explained in foundation. Aftab took 2 lectures. So this is how it's happening. And you need to be connected to that. Now I'm coming to this part. We are talking about shoulder region. So we are looking at axillary artery. So this picture is showing you so many muscles we talked about. What is very obvious is pectoralis major and minor and others. And you can see so many colored things. Beautiful looking stuff. Dangerous. Artery, nerve and vein. And the nerves there's a bunch of nerve, brachial plexus. We'll have a full lecture next week, inshallah. So removed everything, you can see that this artery is going down. Let's look at it shortly. Now, in this image, I'm not talking about plexus here. From my heart, arch of aorta. From left ventricle, arch of aorta. From arch of aorta, I have something going to my neck on the right side, brachiocephalic trunk. One which goes to my neck, common carotid, and one which goes to my upper limb, subclave. Let's label them. Brachiocephalic artery. This is right side. This is going to my head and neck region on the right side, right common carotid, right subclave. Story begins from here. Every story begins from heart. Now, there are branches which are given in this area from subclavian. They are supplying in this region. Okay? Now, this artery, when it crosses the first rib, the name of the artery has changed. The artery started its journey from arch of aorta. When it emerged from arch of aorta, we changed its name to brachiocephalic. Brachiocephalic becomes subclavian. And subclavian, when it crosses the outer border of the first rib, now we call it what? we call it axillary artery because it's in my axilla. And when this artery will cross a muscle down, teres major, we call it brachial artery because it's in the brachium in my arm. And when it reaches to my forearm, it will become radial and ulnar artery. When it reaches to my hand, it will become superficial and deep palmar arch. When it supplies my digits, they will be called as digital branches. This is the whole blood supply of your upper lip. It gives its branches in various directions to take care of because artery carries oxygenated blood for nutritive purposes. So, for our better understanding, we divide it. We call it axillary artery, business artery. It's the name. So this is, but don't write in the exam business artery. Nobody will grade you. If someone else will checking it, what the hell? Who taught this? So this muscle is being shown up here. What's that muscle? Can you see this brown thing? This is my teres major. After that, this artery changes its name. Artery remained the same, but name got changed. When it crosses this muscle, now we call it brachial artery. Are we good so far? Now what happens? A muscle we talk about, pectoralis minor. It goes over this artery. And above to this muscle, we have pectoralis major. So pectoralis minor, when it crosses this artery, when it goes over this artery, so before it's crossing, that is the first part. Under this muscle is the second part. And below this muscle is the third part. So let's number it. One. First part give one branch. Second part give two branches. Third part give three branches. Easy? No rocket science. Nobody's asking you details. Don't waste your time in going further details. What you have to learn, axillary artery begins here, ends here. Divided by pectoralis minor muscle in three parts. First part, one branch. What's the name of that branch? Second part, two branches. What's the name of those two branches? Third part, three branches. What's the name of those three branches? Are we good? So now, second part, these are the branches. And the third part, these are the branches. Very complex slide, too many infos. Let's make life easy. So many names. So same, what is zibda from that previous slide? Axillary artery, continuation of subclavian artery. Begins at outer border of the first strip. Ends normally at the inferior border of teres major, where it becomes brachial artery. End of the story. It's crossed by pectoralis minor muscle. Branches, first part, this is the name of the branch from the first part. Two branches from the second part, three branches from the third part. If you know this much about axillary artery, 80% is done at this level. We will make it complicated when time arrives, not now. If you know this much, enough. On cadaver, where is my axillary artery? You can see that. And this you are expected to see today or tomorrow when you will be visiting the lab. One of the station is talking about the same axillary artery. And you will be, we have placed a prosected cadaveric part, and there you can feel in reality. It's not a picture, it's not a model, it's a real human body part. And you have to see it. If you cannot see it, please, you should be bothered for that. Now, this axillary artery, it gives two branches. This surrounds my humerus. They are called anterior and posterior circumflex humeral artery. Yes? I love your question. I think Oni has not talked about it yet. Artery is more muscular. Vein is thin wall. Color difference, I don't see in real life. You know, when we do surgery, when I do surgery, I don't know, is artery or vein on the basis of location. Artery has pulsations. But dead person, you will not find any pulsation. You put needle, draw blood, color tells, color of blood tells. But it's not a very specific. So location, reference points, texture. Under the microscope, you go confirm, but tell me how. From a normal living person, you take a chunk of the tissue, you send it for histology, they make a section, they need 4 hours to process this tissue under the microscope, then they will confirm it, yes, it is an artery. because it has more muscular part. I'm not going in histology details because Oni and Zafar will be talking more about that in the upcoming time. But I think I have answered your question. On your level, a whitish, a tube which is like, which has some texture, which has some contour. You try to press it, it comes back. Vein, very thin wall. You press it, I doubt it comes back. So this is at your level. But I told you what is the extent. So look at it. Two branches from the third part of this artery, anterior and posterior circumflex humeral artery. Circumflex, they hug around the upper end of the humerus. The part where they hug around, that's called the surgical neck of the humerus. Very important. Fracture of this site, there is a possibility of rupture of these vessels. Bleeding will become, hematoma, swelling, blah, blah things. Disaster can come. And then who's surrounding next? Axillary nerve. So if you are dealing, think, a force which was that strong, a trauma which was that strong, caused damage to the bone. How about artery and nerve? How I confirm it? Patient cannot allow you to move his hand. Touch, sensations. Axillary is gone, no sensation. Period, you know it. Ask him to move, I cannot move my hand. So you're confirmed with that nerve is there or not there. Artery, you have to observe. If it's swelling up, going big, then you should be worried for. So when you see a fracture of upper end of humerus, you should have a suspicion of there might be injury of axillary nerve or posterior circumflex humeral artery, unless otherwise you confirm it. You should live with a sense of suspicion. If you don't have it, you should not practice. If you don't suspect, how you will deal with the situation? If I don't suspect some noisy thing, and if I don't know what could be the possibilities, I cannot deal with this. A patient who comes to you with talking about, I have a sore throat, I have a fever, I have bad taste. If you don't suspect, if your brain doesn't know, oh, this is the time of COVID-19, why not send this person for a PCR? Look for other measures. Period. You can do something. Every COVID patient is not for a ventilator. It's been said, treat everybody as a COVID, unless proven otherwise. Even so many times tests has been done, they comes negative. Anyways, long discussion. Cut story short. What are you looking at? It's a special thing. I know you don't know it yet. This is an angiogram. We put contrast in these vessels. How I know that your axillary artery is fine or not fine? I put a contrast, take x-rays. So it can show to me, something which is shown very clearly in this image, and that's important to know. What is that? This one, where the black arrows are. This is an aneurysm. What is an aneurysm? Abnormal dilatation of an artery. This is a pathological condition. Now, if somebody has an aneurysm, this is a weakening. It can rupture. A major artery rupture, you'll see someone dying in front of your eyes with infections. Not because of this aneurysm, but abdominal aorta aneurysm and other aneurysm. Period. You don't have time. Rush. Open and just put clamps and then do repairs. If you're not trained, khalas. So aneurysms are dangerous, and this can happen. There are so many reasons for that. So you can see that how axillary artery, it's supplying your upper limb, but it also makes a channel around the scapula. Nowadays, for last many years, you go out, you want to go to Alaya Street. Tahwilat, tahwilat, tahwilat. What's that? Detours. The roads have been closed. You go from this street, go from that street, you cannot go from here, you can go from here. So there are so many cross channels. If even, how we design questions. If axillary artery is being damaged at its second part, blood can still reach to the upper limb. How? So if you know these channels, they will help you in solving those problematic situations. And you need to be good with that. Let's say if you find a notice that tomorrow morning Khores will be blocked for some VIP movement from morning till night. So people will use other channels because, and those are what? Tahwilat, detours. So same is the vascular channels. So these vascular channels become more prominent for that pertinent period. So the traffic will be diverted onto the other roads. Same is happening. So we need to be good with these alternate channels. Are we good? Okay. So now concept check. We talk about it. We started our journey from Sunday. We have so many sessions for various reasons. So let's see how much you learn. Can you answer my question? Mice, can you check the inbox? No, because I have thrown this question. This is for the class to answer. So what muscle is involved in this type of injury? So most likely I told you suspect supraspinatus. Fan-shaped muscles that insert along the anterior margin of the scapula and its vertebral border and act to protect the scapula. Who's that? Serratus anterior. What is the primary muscle producing abduction at the shoulder joint? Perfect. What two muscles produce extension, abduction, and medial rotation at the shoulder? This is how we ask you. So answers has been given here. So you need to be quick, precise, to the point. Are we clear? So we are done with this first half. So guys, these are the tables. You may use these tables. You need only this much about a muscle. Proximal attachment, distal attachment, nerve supply, action. If you know this much, enough. No need to go over pages and pages. This is all those muscles which we have just learned. So we are done with this part. You can take 2 minutes break. I know those who are sitting here, they cannot take a break. But those who are sitting in their homes, grab a glass of water or coffee or tea or whatsoever you're enjoying. Have fun. And then we'll start with this lady. Always I bring some problems. But at the end is good. Lujain, what you have started? Move fast. Next session is more important.
Someone is asking me if the second part of the axillary artery is damaged, is the first part working?
If you establish the collateral, because I have explained to you there are collaterals, so it will work. So only you need to understand. I gave you an example. If Khores is blocked, still you can reach to your destination. You can use Malik Fahad, you can use Takhasusi. So this is the same pattern which has been followed by these. I'll start at 9:30. I'll finish it. It's not that long. Actually, this was the first lecture. It has so many things. And people have so many questions, beginning of the blog. Thank you. Guys, I'm done with the time. Let's start. So now, what's the problem with this lady? Any idea? Her shoulder. Yes, excellent. I love it. What is wrong with her shoulder?
It's like pointed out.
Look at her hand, what she's doing. She's holding, so as if her hand is falling out. And look at the deltoid place. Thank you very much. Dislocation. Excellent, good idea. You can be a good doctor. Just looking at, wow, no need for x-ray. Great, but you know, this, I love it. You did a nice move. So now today we'll be talking about joints of the shoulder region. It's not one joint. We'll be dealing with more than one joint. So now these are the objectives. You can read it. I know them. So these are my joints of focus. They have been highlighted in these blue boxes. 3: glenohumeral, acromioclavicular, and sternoclavicular. The place where sternum meets with the clavicle, the place where acromion meets with the clavicle, and the place where head of the humerus meets with the glenoid cavity, which is located on the lateral aspect of the scapula. Now, shoulder joint, the word shoulder joint is not one. There are so many, and these circles have been showing those. Basically, joint means where two structures meet. It's not necessary that two bones. Scapula meet with my chest wall, that's also a joint. Can't we say that? Glenohumeral, yes, established joint. This is glenohumeral. This is acromioclavicular. This is sternoclavicular. Now tell me, which is the only joint which connects the upper limb with my trunk out of these? Bony joint which connects the upper limb with the trunk. Clavicle is a joint. Name the joint which is the bony articulation between the upper limb and my body. Sternoclavicular. Excellent. Other joints, because you know the humerus joins with the scapula, but scapula is not joined with my body with a bony attachment. Acromion is attached to the clavicle, but it's not. This is not the primary joint which connects my upper limb to my body. The primary joint which connects my upper limb through clavicle to the sternum. That was the question. So you should be clear about these things. So guys, shoulder joint is a typical ball and synovial joint, most mobile, more prone to injuries. Sports injuries are very common, and rotator cuff are the chief stabilizing factor. Don't forget that. Now, patient, when he visit to you, he'll have a story. I fell down, I got hurt, somebody hit me during a game, during a play, during a fall, during a trauma, during an accident. But you need to be good. You should be able to identify these bony features on the given x-rays. This is not clinical. This is basic, simple anatomy. That where is the head of the humerus and where is the glenoid cavity and where is this and where is that. Are we good? Now, I'm showing you a frontal section, different views of glenohumeral joint, which is famous as shoulder joint. So you're looking at what? From different views, through an X-ray, through an MR. This MR is being highlighted, the same MR, we've drawn it, and this is a real anatomical section. So this picture is showing you, this slide is showing you different aspect of the frontal view which has been taken through the glenohumeral joint. And you can see that a big head of the humerus is joining with a very small shallow cavity called glenoid cavity. So this ball and socket, there's a big disparity. Ball is too big and socket is too small. So to increase this, we need other extra forces. And you can appreciate here, what you should appreciate here. Can you see these rotator cuff muscles? They are going above, side. So they are keeping the head of the humerus towards the body after getting attached on them. Are we good? So now, different views. So you are looking at, in this image, let's say here, the glenoid cavity, head of the humerus, different angles. and you are looking at this joint, and you are seeing in this X-ray image. So this is how these articulations are occurring. Are we clear? Guys, when we talk of a joint, what you should know about this joint? Number one, is it a fibrous joint, cartilaginous joint, or a synovial joint? Now this is a synovial joint. Now which type of synovial joint? Ball and socket. You have answered. Maybe out of 10, 2 marks have been answered. Articulating surfaces, head of the humerus, glenoid cavity. 1 more mark has been added. The most important factor, the ligaments of this joint. So ligaments are what? The binding forces. Okay, you give 4 marks to that. So you have scored around 6 or 7 marks. And the last mark goes for what? Last 3 marks. The stabilizing factor for this joint. And movements occurring at this joint. If you know this much about a joint, nobody can fail you in that question. So for my shoulder joint, the most important major stabilizing factor is rotator cuff muscles. The name of the ligaments are glenohumeral ligaments, primarily. Movements, flexion, extension, abduction, adduction, circumflexion. Who brings these movements? You're done. This is what I'm going to talk in the coming 10-15 minutes. If you know this much, khalas, zibda. So, let's make it. I know everybody knows about these structures. So this is the humerus bone, head of the humerus. Let's label it, we talk about these features. Can you see this red dotted line? What's that? Anatomical neck. And this plate, where is another arrow, that's the surgical neck. You remember just before I talk about surgical neck, and I've shown you an image where anterior, posterior, circumflex humeral arteries and axillary nerve were surrounding this part of the humerus bone. So if there is a fracture, these structures are vulnerable to injury. Now, lesser tubercle, we talk about it, where which muscle was attached? Subscapularis. Greater tubercle, SIT, supraspinatus, infraspinatus, and teres minor. So now, what is that? Coracoid process, crow, beak of a crow, ghurab, coracoid, acromion, notch, clavicle. Are we fine so far? Yes. These are the anchors which keeps the clavicle to be attached with what? These are ligaments, but they are attaching the clavicle with what? Coracoid process. Why acromion? And they have names to them. And they are connecting coracoid to the clavicle. Coracoclavicular ligament, and there are two. And then between the acromion and the clavicle, acromioclavicular ligaments. Between the acromion and the coracoid, coraco, acromial. Guys, these ligaments which I'm showing you, they are not part of my glenohumeral joint. They are different other joints. So now another ligament which covers this notch. Now, let's talk about glenohumeral joint. First ligament, fibrous capsule is also a ligament. Now this fibrous capsule is reinforced by something, and those are glenohumeral ligament, fibrous joint capsule. Can you see that there is a notching here at the bottom? Can you see it's hanging down? Why is that? What's that called? Guess. You know your sleeve, if it's very tight, and if your cloth is not flexible, you move it, you abduct it, and you can hear a sound. Your shirt is gone. So for the freedom of movement, this capsule is not very tight. It's not adherent with the body. And that is axillary recess. So that provides freedom at my shoulder joint, at my glenohumeral joint, while I'm bringing various movements. Now this joint, glenohumeral joint, inside the fibrous capsule is reinforced by certain ligaments. They are inside the fibrous capsule. And this one, what's the name? Coracohumeral. It connects the coracoid to the humerus. And this one, what's that? Superior glenohumeral. What this should be? Middle glenohumeral. And what about this? Perfect. You guys are smart. So primarily these ligaments are surrounding or connecting the head of the humerus to the glenoid cavity, and they have been covered by fibrous joint capsule. So primarily these are the major ligaments of my joint. Which joint? Glenohumeral joint. So these are capsular ligaments. They are present within the capsule. They are not outside. Now, a muscle of my arm, biceps, it has two heads, long head and short head. One head goes through a sleeve and it goes over. It passes through that. And it's been anchored with the humerus with a transversely placed ligament. But that's not part of the shoulder joint. Are we good with this picture, guys? If you know this much, you have done 70% of your glenohumeral joint. You know the type, you know its ligaments. Are we fine? Now this is another view explaining the same stuff. Now you can see that how my rotator cuff muscles, they are connecting this humerus towards the body through this supraspinatus, infraspinatus, teres minor and subscapularis. Are we good?
They're asking you, doctor, what is a tendon sheath, and what is a tubercle? And if you could kindly repeat the ligaments related to the glenohumeral.
Glenohumeral ligament, the ligaments are, what were those? Just read this. Number 1, superior glenohumeral, middle glenohumeral and inferior glenohumeral. These are the primary ligaments. And then on top of them was coracohumeral ligament and fibrous joint capsule. So these are the ligaments of my shoulder joint. Now the tubercle is this is the bone marking and elevation. Above to this glenoid cavity, we have a supraglenoid tubercle, and below to this glenoid cavity, we have infraglenoid tubercle. Now, I told you about this slide. We talk about this slide. Axis of the movement changes. I move my shoulder in this direction. Internal rotation, external rotation. I move in this direction, coronal plane, frontal plane, abduction, adduction. I move this direction, flexion, extension in sagittal plane. So this change of plane changes everything. Now, I'll be further explaining what is supra-infraglenoid tubercles. This is my glenoid cavity, is reinforced by a hyaline cartilage. We call it glenoid labrum here, acromion process, coracoid process. It is further, the cavity has been decreased by additional padding. We call it glenoid labrum. This is the tendon of the long head of the biceps which was going and attached to the supraglenoid tubercle here. Now, this is a section, fibrous joint capsule, and we know that inside this fibrous joint capsule, we have superior, middle, and inferior glenohumeral ligaments. And this is that recess. And that's the weak area. How it's weak. Now see that. Who this muscle should be, guys? Guess. Supraspinatus, perfect. Who this should be? Infraspinatus. Who this should be? Teres minor. Who this should be? Subscapularis. Now see what? This joint is covered in the back, covered in the front. On top there is a very strong ligament between this and the bony structure. but it's weak here. There is nobody covering it here. So if there is any trauma, the head of the humerus will dislocate downwards, get out of its space, dislocation. So the first event, if my joint dislocates, head of the humerus move out of the glenoid labrum, first it goes out because inferiorly it's not strong. If this room is being well structured, but on one side there's a hole, that's a place from any Alibaba can come and steal the things. But if you put a lock, everything is secure, there are less likely chances. So the weak area is inferiorly. Anteriorly it's supported, posteriorly it's supported, and superiorly it's supported. Are we clear about that? And who's doing it? Sits. What muscles are these? Rotator cuff muscles. And now this is my bursa. We talk about this. This is a very strong approach. So it prevents, it never happens, very less likely that the head of the humerus pops out upwards. It always goes downwards. Then it may go in front or it may go behind. It depends on the mechanism of the trauma. But superior dislocation is prevented by this coracoacromial arch, which is reinforced by this coracoacromial ligament. Are we good so far? This is my deltoid. So everything is being kept. So only the weak part is inferiorly. And this is my tendon. Triceps muscle is there. So now, only the weak part, head of the humerus, pops out inferiorly first. Dislocation. Are we good? Now, let's make it fast. We know it. Why it goes down? Because it's the weakest area. So, head of the humerus pops out of its glenoid cavity. And now this is a dislocation. Are we clear? Now, showing you again the same thing which we have just talked about. Now, tell me this X-ray. What are you looking at? Is it a normal X-ray or abnormal X-ray? Perfect, normal. The head of the humerus well placed in the cavity. What about this? Abnormal, excellent. It's anterior dislocation. It comes out inferiorly, then it goes anteriorly. Why? Because pectoralis major and subscapularis, they pull it towards the body. That's why you remember the first picture of that lady? The hand, she was holding the hand and it was towards the body. Now, what about this? Why posterior? Why not anterior? Even the picture is supporting, is anterior dislocation. And what about this? Posterior dislocation. Can you see that it's going backwards? See very clearly here. Where? At this place. Look at the head and it's going posteriorly. What's that? So this is going backwards.
Doctor, they're asking you what happens to the muscles and ligaments if the dislocation happens?
They are a possibility they may damage. It depends on the force of the trauma. Oh, I'm sorry. I was going backwards. I said what happened. Are we good so far? Now this is the factor which brings it towards the body. Internally subscapularis, externally pectoralis major. So if this head of the shoulder, head of the humerus gets out, it will be pulled towards the body by these two muscles. So what is this? Dislocation. It goes inferior, then it may go anterior or it may go posterior. Depends. And what about this? Dislocation plus fracture. So we need to understand the difference. Okay, what difference you see in this image? So the head of the humerus, the contour of the shoulder is gone. So you don't see a contour here. You compare this shoulder with this shoulder. Look at the difference. Because head of the humerus is not in its place. So this area becomes empty. So this is how the patient will appear. You just look at the patient, you can tell dislocated. No need of X-ray in the first place. You confirm it. You have to confirm it. Now, when this head moves or fractures, so many important structures are there, we should be bothered with that. What about this? Fracture, excellent. Fracture where? Surgical neck. If this fracture, think for axillary nerve, posterior circumflex humeral artery. So, we do at the end of the story. Give this sling and patient is fine. I still not forget, 8-year or 9-year-old child came to my ER, the hospital where I was working, and it was just a clavicular fracture. I gave the sling. Mom said, "What the hell, the doctor you are? I came here all the way, and you're just giving me this sling, and you're telling me to go away, and it will be fine." She put out the sling and thrown on my face. I said, "No, this is the standard treatment. You have to take it." Anyway, so it can happen. Be careful. Patient always expects. So what I'm showing you here? This is arthroscopy, kind of a laparoscopy, kind of a manazir. You put the scope into the joint space and you are repairing these intracapsular ligaments. You are working on different pathologies. This is the common practice nowadays. Arthroscopy. You can go into any joint space. These instruments are very fine, thinner than a pencil. And you can operate, you can work, you can see diagnostic and treatment. And this is the view. When you put this scope in, this is how it looks to you. Got it? Now, these are the prostheses. If someone has serious problem, now the era of prosthesis is there. You put these prostheses, the problem is gone. But it's the last resort. Not every fracture don't carry this message that every fracture needs a prosthesis. But this is the summary of all what muscle and what brings about. And this much if you know enough about shoulder joint. Now, we talk about this. Nothing new. I'm sure everybody is familiar with this picture. What about this ligament? Who connects the two? Intraclavicular ligament, sternoclavicular ligament, coracoclavicular ligament, acromioclavicular ligament. Are we fine? Clavicle moves, we don't see it. Now, what I'm doing? A joint between sternum and clavicle, sternoclavicular ligament. Can you see that? This is the ultimate thing if you know from this joint. What type of joint, what is happening? Not so many movements here. This is another acromioclavicular. Fine? Ligaments, names, movements. Now what happens? We know about this. You're looking at acromioclavicular ligament. Someone falls. As a result, injury, these ligament damages. Now when this dead damages, the clavicle is free from the lateral end. It goes up because anchors are gone. So this is called shoulder separation. If this happens, patient will appear like that. Look, the clavicle and acromion process, they are not in the same line. Can you see the red line which I'm showing you in this image? Before they were aligned, now it has moved. Because the clavicle, those ligaments who were supporting the clavicles, who are those? Acromioclavicular, coracoclavicular, they are all damaged. So this lateral end of the clavicle is free. So my shoulder is separated. So patient hand is like falling down because shoulder is separated. The head of the humerus is in its place, but the connection, the main communication with the body is gone. So you should understand what is shoulder dislocation and what is shoulder separation. That's the point. Now, look at this car. This is a real story. This car fell down from this highest part of this valley. And this is the picture after this is a real thing. It occurred to someone who is known to me. This is the picture of the car. And what happened? This is his X-ray. Shoulder suppression. Then what we did on him? These are the gradings, how we grade. If you don't know it, it's good. We put this device. I have it with me. Healed, removed. Back to the normal life. Yes, through the surgery. You know why I was showing you this? If it was grade 1, grade 2, no need for surgery. But this injury was grade 5. So you need not to go into this detail. Sorry, don't bother for that. So this is how it has been treated. It's fixed.